Hello and welcome to the Spine Nerve Podcast. My name is Dr. Brian Joves.
And my name is Dr. Nicolas Karvelas.
And thank you everybody for listening and paying attention and sharing the podcast. We appreciate you joining us. We are going to continue our lecture series or discussions on some common pain ailments for patients. And kind of today we're going to focus on post herpetic neuralgia. And so this is a diagnosis that I think probably a lot of people see, not just in the pain medicine world, but also in primary care. And hopefully we can shed a little bit of light on the diagnosis and the pathophysiology, but also onto some of the treatment options that we have for patients. So Dr. K, can you tell us a little bit about post-herpetic neuralgia?
Yeah, and part of our intent with this talk is obviously to give a strong background in regards to post-herpetic neuralgia, and as a consequence, herpes zoster or shingles. Obviously, they go hand in hand there. So we want to give a good background on that, and then ultimately we want to make sure we'll try to power through that to some degree, because we do want to talk about a study at the end, which involves a procedure that both Dr. Joves and myself find to be effective for our patients. It does have one of the things I like about it is, everything in medicine is risk and benefit. And it's an incredibly low risk procedure that has quite a few different applications, but definitely chronic thoracic region pain due to something like post-herpetic neuralgia or trauma or rib fractures. That's one of its strongest areas in terms of the degree of literature the amount of literature that's available for it. So providing that background that we had brought up. So herpes zosters, also known as shingles, is caused by reactivation of the Varicella Zoster Virus, which, as we know, commonly causes chickenpox, typically in our youth. In terms of epidemiology, this is a fairly common a disease process, with about 1 million cases of herpes zoster shingles occur in the US annually. The individual lifetime risk of developing shingles is about 30%. Now, one thing I would say is that, as we know, there's two vaccines that are currently available, with Shingrix being the more recent one, and that has, at least based upon the data we currently have, really good efficacy with over 90% prevention of herpes zosters, and as we know, recommended for elderly individuals over the age of 60. That being said, there's still going to be a lag time because the previous vaccine, Zostavax, didn't quite have that efficacy. I think it was closer around 50 to 60% effectiveness. And so there's still going to be a lag time where we're seeing these cases of post-herpetic neuralgia. And in addition, there's still some limitations, which we'll talk about at the end, because with the initial vaccine, the Zostavax, there was quite a bit of caution if the patient was immunocompromised. And as we'll discuss, being immunocompromised is a huge risk factor for developing post-herpetic neuralgia. And so there isn't quite a complete consensus yet on with the newer vaccine in regards to whether or not it can be consistently and administered without concern to patients who are immunocompromised.
Yeah, well, I think you kind of introduced the next question pretty well. And so, what are the things that tend to make people at increased risk for post-herpetic neuralgia?
Yeah, and they're kind of similar in terms of the risk factors for herpes zoster and post-herpetic neuralgia. Starting with herpes zoster, the risk factors include age. Age is a huge one. It's a major risk factor due to multiple factors, including your cell-mediated immunity, or your T lymphocyte specific immunity goes down with age. And knowing what we know about the reactivation of the Varicella Zoster virus, if that cell-mediated immunity goes down, it's going to increase the chance or the probability of that occurring. So age, immunocompromised, as we discussed, especially an immunocompromised state that affects that cell-mediated immunity. Patients who have that immunocompromised state are at 20 to 100 times increased risk relative to age-matched controls to develop herpes zoster, and then ultimately, obviously, being at increased risk for post-herpetic neuralgia as well. Also, Some other risk factors include women having an increased risk as well. And just to give a sense of that age again, so for patients over the age of 85 who are not vaccinated, epidemiologic studies will show that over 50% of those patients will be affected by herpes zosters. So definitely fairly prevalent, especially in that elderly population without the vaccine.
Yeah, that's a pretty high percentage for sure. So, I mean, how do these patients generally present? You know, if they're coming in, and so now we're starting to think about herpes zoster and post herpetic neuralgia. What are the ways that they're showing up to the office?
Yeah. So again, we'll start with the herpes zoster, obviously just following the timeline of the disease here as well, but and then we'll get into the clinical presentation of post herpetic neuralgia as well. But and again, I'll try to power through this part just so that we can get to the post herpetic neuralgia and, like I said, that study. So, you know, for the clinical presentation of herpes zoster, so after the initial Varicella Zoster virus infection resolves, the viral particles, as we know, travel to the cranial sensory ganglia and dorsal root ganglia, and therefore during our majority of our lives, they're shielded from the antibodies in the blood. That virus remains in the cranial ganglia and in the DRG, but it can be reactivated when the cell-mediated immunity wanes or other factors. But like I said, that decrease in the cell-mediated immunity is a huge risk. So under these right conditions, the aforementioned the virus reactivates and replicates and causes a non-specific prodrome. So, you know, in terms of that clinical presentation, the first thing that we're going to see from our patients clinically is this non-specific prodrome, which can include, you know, just general fatigue, malaise, headache, fever, abnormal skin sensations, including itching, burning, pain. Then the classic maculopapular rash in a specific dermatomal distribution, although of note, again, going back to the fact that, especially moving forward as this vaccine becomes more and more prevalent, and we may see more of a percentage of immunocompromised states. So keeping in mind that although classically it's in that specific dermatomal distribution, it can cross dermatomes, especially in an immunocompromised patient. But so that classic maculopapular rash is going to occur 2 to 3 days from the onset of the prodrome. Typically, like I said, it's going to be unilateral. But another point is that it can cross to become bilateral, especially if it's involving the back, and again, especially if it's in an immunocompromised state. Now, the time course of those lesions, so the lesions typically progress to clear vesicles and then become more clouded and then crust over. And that's ultimately over a course of about a week or 7 to 10 days. Typically, they're going to be healed about 2 to 4 weeks from time of onset. That being said, it's not uncommon to see scarring or increased skin pigmentation. The most common nerves that are going to be involved are going to be T1 to L2, and then also the ophthalmic or first division of the trigeminal nerve can be involved fairly frequently as well. Some studies in terms of how frequently adjacent levels are affected document that up to about 20% of cases, there can be adjacent dermatomes affected. Now, in terms of the diagnosis and management, again, just real quickly here before we jump into post-herpetic neuralgia. So typically this is going to be a clinical diagnosis. You want to think about, you know, PCR testing of potentially that the fluid in the vesicle, only if there's really a question about the diagnosis or, you know, or some atypical characteristics of the presentation. That PCR testing is really accurate with a 95 and 100% sensitivity and specificity, respectively. The management, as we know, antivirals, acyclovir, valacyclovir, potentially a course of oral steroids, but importantly, that course of oral steroids, although it's been associated with an accelerated time to healing of the lesions and a resolution of the pain at an earlier time point, it had not been shown to decrease the incidence of post-herpetic neuralgia, which is as a quick preview of our study. Interestingly enough, there's a procedure that potentially can decrease that incidence of post-herpetic neuralgia when you have someone who has developed herpes zoster. So
So you've alluded to this study. You've done a really good job of leaving cliffhangers for people talking about it. But before we get to this magical, mythical procedure, can you just give us a little bit of differentiation between that initial viral infection and then the difference of it becoming post-herpetic neuralgia?
Yeah, and so, post-herpetic neuralgia, it's the most common complication of herpes zoster, and it's defined by pain. That typically it's going to be obviously a burning, electrical shock-like pain. It can be associated with hyperesthesia or allodynia on exam. And this pain is sustained for at least 90 days from the time of the rash. And that's really what puts it into that diagnosis of post-herpetic neuralgia. The thought process is that post-herpetic neuralgia is caused by injury to the nerve due to the inflammation that occurs as a consequence of the viral reactivation and replication, leading to that nerve injury and ultimately the neuropathic pain. And now we talked about the epidemiology of herpes zoster, but in terms of the epidemiology of post-herpetic neuralgia, this occurs in about 20% of patients who have herpes zoster. And if you look at those patients who develop post-herpetic neuralgia, about 80% of those patients are going to be more elderly patients. So again, age being a strong risk factor, not just for development of herpes zoster, but also of post-herpetic neuralgia. Other risk factors for post-herpetic neuralgia, like we mentioned, that older age, but also the severity of the herpes zoster itself. So was it a very painful, acute and subacute infection? Were the prodrome symptoms severe? Because the severity of those symptoms has been shown to increase your risk of developing that post-herpetic neuralgia subsequently. Whether or not the ophthalmic is involved, like we have brought up that first division, if that is involved, the chance of post-herpetic neuralgia does increase. Obviously, immunosuppression, and then other chronic comorbidities, including diabetes and lupus.
What's the normal treatment pattern? So we have these patients coming in, we've got herpes zoster, treating with antivirals. If they start to develop signs 90 days later, post-herpetic neuralgia, continued pain, what are the things that we're starting to think about as far as treatment options for the patients at that point?
Yeah, and so there are a lot of different guidelines out there in terms of what medications to consider, and a general consensus is that topical medications can be helpful. Two of the major ones are topical lidocaine, specifically in the form of the lidocaine 5% patch. The data, including recent Cochrane reviews, is a little conflicting there in terms of how efficacious it is, but it's an incredibly low risk treatment, and I think it's good as a first line, because if it works for the patient, great, you found something that's very low risk and easy for the patient to use, that's effective for them. In contrast to capsaicin, which actually has some pretty good data behind it, but can be very painful for the patient just to apply. And so typically, I know for my fellowship at UC Davis, we would bring the patient in and administer at least topical medication, topical lidocaine, prior to the application of the capsaicin, and sometimes even some IV medication to get them through the application. But strictly in terms of what the data shows, so there was a meta-analysis of 4 randomized controlled trials, over 1,000 patients, so fairly good number of patients. And what they found was that the 8% patches of the capsaicin applied for 30 to 90 minutes were found to be significantly superior to their comparison, which in those studies was a low concentration of capsaicin. The number needed to treat in this analysis was 7, which, compared to some of our other neuropathic medications like gabapentin, pregabalin, is pretty comparable. But like I said, it can be pretty painful, and the recommendations are that there's some supervision by a physician for the application of it.
Yeah. Unfortunately, the high percentage capsaicin isn't the easiest tool to be able to utilize for patients.
Yeah.
What about like medications and things along those lines? What kind of things do we think about as we're trying to help a patient through the post-herpetic neuralgia?
Yeah, and so as we brought up, gabapentin, pregabalin, we reach for those often in the setting of neuropathic pain. And so for gabapentin, it's FDA approved for treatment of post-herpetic neuralgia. The number needed to treat for gabapentin is around 8. Typically, you're not going to get that efficacy until you get to at least the 600 milligrams 3 times a day. And so, similar for gabapentin and pregabalin, some of the limitations there is that usually, these are elderly patients potentially with some comorbidities. So you're going to have to start at a relatively lower dose and titrate up, and that can take time. And then as you titrate up, you may be there may be complications in terms of side effects, oversedation, maybe some swelling with pregabalin. So it's not without the potential for side effects, especially as you try to get to those doses that have been shown to be effective. So like I said, usually around 1800 milligrams for gabapentin, and then for pregabalin, typically you have to get to around 600 milligrams per 24 hours, whether that's 300 BID or 200 TID dosing. Better number to need to treat with pregabalin, around 4, and it's also an approved medication for the treatment of post herpetic neuralgia. As we brought up in prior talks, tricyclic antidepressants, obviously amitriptyline, nortriptyline, do have pretty good effectiveness for these neuropathic pain conditions. With, when we look at the number needed to treat for those medications, it typically is going to be a little bit superior compared to some of our other options. But again, not without potential risk for the patient, which we'll emphasize in a second. But so strictly in terms of nortriptyline, amitriptyline, they did have a meta-analysis for that as well, 4 randomized controlled trials. And what they found was a number needed to treat of 3. So a little bit superior to even the pregabalin with a number needed to treat of 4. But again, like I said, adverse effects are definitely something we have to be very vigilant for, especially in our elderly population. We can see confusion, sedation, urinary retention, cardiotoxicity. So you really want to try to avoid these medications in the elderly patient, especially if they have cardiac comorbidities, especially cardiac arrhythmias. And you want to be obviously cautious if the patient's on other serotonergic agents as well, because as we know, amitriptyline, nortriptyline can raise your serotonin levels quite a bit.
Yeah, it is the challenge with tricyclics, right? The data is good, but especially when we're talking about post-herpetic neuralgia, where there is this significant skew towards an older demographic, TCAs are not at all ideal for that demographic.
Yeah, right. And we didn't want to finish talking about treatment without talking about prevention. Obviously that's important in every aspect of medicine. And like I said, there's 2 vaccines, the Zostavax and the Shingrix. The Shingrix being the more recent addition, and it has very good data. The most recent data I saw from the CDC with a 97% effectiveness in preventing herpes zosters, and it is recommended for patients 60 and older. But as I had brought up, the Advisory Committee on Immunization Practices still is determining if Shingrix is recommended for patients with significant immunocompromised states. So as far as I know, they haven't put out a formal statement on that. And so, like I said, we still have this significant patient population, immunocompromised due to X, Y, or Z reason, who is going to be at risk for developing herpes zoster and ultimately post-herpetic neuralgia.
Yeah, and I think one of the things that I'd like to emphasize, and I think it goes along with just about every kind of chronic, especially chronic neuropathic pain process, the time frame in which we treat these patients is really relevant, right? I mean, the longer that a patient is dealing with the symptoms of post-herpetic neuralgia, the harder that becomes to treat. There's a lot of data that suggests that by the time you get to the 6 to 12 month mark, it is significantly harder to get those patients under better control than if you're able to address things earlier, which I think does flow kind of into the study that Dr. Karvelas is about to present, because the more aggressive that we are up front in trying to limit these symptoms and get them controlled, the better off we're going to be at overall not having this become a significant chronic pain problem for the patient.
Right. Yeah. And so, I think, like you said, leads perfectly into this study. So this was a study published by Dr. Lin and his colleagues in Pain Physician in 2021. The title was The Effect of the Erector Spinae Plane Block on Prevention of Post-Herpetic Neuralgia in Elderly Patients. Essentially, previous studies, which I think we've talked about in the past, have demonstrated the effectiveness of the erector spinae plane block for the treatment of post-herpetic neuralgia when it develops. But as far as we know, there hasn't been any other previous study that actually showed the prevention of post-herpetic neuralgia. And so the objective of this study was to evaluate the effect of repeated. So ultimately, as we'll talk about, they did 3 blocks sequentially. Repeated erector spinae plane block on the occurrence of post-herpetic neuralgia in elderly patients with acute or subacute herpes zoster. And so their methods, it was a randomized controlled double-blind placebo-controlled trial. The patients were clinically diagnosed with acute or subacute herpes zosters, and then they were randomized to receive either an ultrasound-guided erector spinae plane block or placebo cutaneous injection every 24 hours for 3 days. And so just as a real quick, in terms of the logistics of the injection, so the erector spinae plane block, like I said, it was done with ultrasound guidance, and it was 25 milliliters of 0.4% repivacaine. I know for myself, when I do these, I do about 20 cc's of 0.25% bupivacaine, and sometimes I'll add a little bit of dexamethasone, depending upon the patient and the risk factors. But like I said, in this study, it was 25 cc's of 0.4% repivacaine. The placebo group was, the injection was done in the exact same manner, ultrasound guided, but they instead just injected 2 mLs of saline into the subcutaneous tissue rather than going all the way to the transverse process into the erector spinae plane. Ultimately, 50 patients completed the study. In terms of the whole 12-week follow-up, 52 patients originally enrolled, 50 completed. The results, so the incidence of post-herpetic neuralgia at 12 weeks was significantly lower in the erector spinae plane block group, with an incidence of around 15%, or 4 of the 26 patients in that group, compared to around 41.7% occurrence of post-herpetic neuralgia in the placebo group, with 10 of the 24 patients developing post-herpetic neuralgia. So obviously a significant statistical difference there. In addition, they did have some secondary outcomes that they took a look at: VAS score, the short form McGill pain questionnaire. They also looked at depression, anxiety scores, and sleep disturbance. And so what they found was that the VAS scores, and they measured those time points at the 12-week follow-up as well, and they measured the pain scores at 1 week, 4 week, and then the 12-week as well. And what they found was that the erector spinae plane block group had significantly superior outcomes in all of those measures as well, in terms of pain, depression, anxiety scores, as well as sleep disturbance. And so their conclusion was that for elderly patients with acute or subacute herpes zoster, the erector spinae plane block reduces the incidence of post-herpetic neuralgia at 12 weeks after treatment. It also decreases the occurrence of pain, sleep disturbance, and depression, anxiety during that acute and subacute course of the herpes zoster.
Yeah, I mean, I think this is, I mean, it's a really interesting study because they are trying to get these patients before the full development of post-herpetic neuralgia. But I mean, even if looking at it with this intervention, I think seeing the percentage of patients that have post-herpetic neuralgia, even with intervention, was pretty striking. I mean, it is, you know, it's still, I mean, 15% is still a pretty significant amount. And then, you know, over 40% in the placebo group. I mean, those are very high likelihoods of post-herpetic neuralgia. And so, I mean, I think, you know, overall, it's just kind of lends towards really trying to be a lot more aggressive up front, right? I mean, I think from the perspective of somebody that does what we do, where we tend to see these patients, you know, 6, 12, 18 months later, when they're developing a lot more symptoms of post-herpetic neuralgia, it would be interesting to see them follow these patients out to those timeframes to be able to see the difference. But already seeing such a drastic difference off of, you know, early intervention when it's still treating the herpes zoster, I think was really, really interesting.
Yeah, and you know, and from I mean, obviously the most important thing is the patient outcome and their health ultimately, but then also in terms of resource utilization, doing 3 very low risk, relatively inexpensive blocks up front, because we know managing these patients long term, the amount of patient visits and medications and other interventions, maybe even neurostimulation that we ultimately have to try to utilize to give them some quality of life. So it is a potential. I know that they chose three procedures here, so a potential of 3 procedures, but like I said, relatively low risk and inexpensive interventions for potential significant positive effect long term.
Yeah, and I mean, even you brought up that normally when you're doing it, or that you are utilizing steroid in that setting. I mean, this was not done with steroid, and so I mean, obviously the variations off of this study that can be explored to be able to see if we can get even better response and decrease that incidence of post-herpetic neuralgia, because it is a disease process that once it's set in, and like I said, unfortunately by the time that we usually see these patients, when they're 6, 12, 18, hopefully not longer than that out, it can become a very, very challenging disease process to be able to treat. Cool. Well, any final thoughts on this study or on herpes zoster or post-herpetic neuralgia you want to leave our audience with, Dr. K?
No, that's it. Thank you.
All right, guys, stay tuned for those legal disclaimers. Thank you for listening. Hopefully you guys took something away and learned something from this discussion, and we will talk to you next time. Later.